Good evening, ladies and gentlemen. Hope you all have received the first dose of COVID vaccine and are doing well. In fact, by now, many of you must have received the second dose as well. So hope everybody is fine and healthy. I'm Dr. Tulika Jha, Clinical Secretary, BOGS, and I welcome you all to this CME on Perinatology, which our society has organized in association with Genetics and Fetal Medicine Committee of FOGSI. We have two sessions. In the first session, we have talks by two stalwarts in the field of perinatology. First, we have Professor Mandakini Pradhan, who is also the Chairperson, Genetics and Fetal Medicine Committee of FOGSI. And she will be talking about the genetics of fetal loss. Next, we have Professor Sukumar Barik, who will be speaking on antenatal corticosteroids, controversies and consensus. In the second session, we have a panel discussion on the enigmatic subject of intrauterine infections, which will be moderated by Dr. Sita Ramamurthy Pal, and which has a panel of esteemed faculties, and I'm sure it will be a very interesting and lively discussion. So now to set the ball rolling, I invite our Honorary Secretary, Dr. Ramprasad De, for his opening remarks. And over to you, Dr. Ramprasad De, and welcome to the virtual dais.
Thank you, Dr. Tulika. A very good evening to all of you, respected my seniors, juniors, my faculty members of BOGS, as well as the members of the Bengal Obstetric and Gynaecological Society, as well as the other delegates and viewers. A very, very happy New Year, COVID-free 2021 to all of you. As a Secretary of Bengal Obstetrics and Gynaecological Society, I take the opportunity to welcome you all in the CME on Perinatology in this e-platform. We have a galaxy of stalwarts for these sessions, and we are happy to say that this CME is organized by Bengal Obstetrics and Gynaecological Society in association with the Genetics and Fetal Medicine Committee of the FOGSI, or the Federation of Obstetrics and Gynaecological Society. We are happy and we are fortunate to have with us today the Chairperson of the FOGSI Fetal Medicine, Genetics and Fetal Medicine Committee, Dr. Mandakini Meg, as well as our neonatologist, Dr. Vijan Saha from All India Institutes of Medical Science, and who is presently working in the IPGMR Kolkata, along with our own BOGS faculty, who are very, very stalwart. They are working for more than a decade in this technology, and I hope they are also, not only hope, I expect that they are very much expert in the field of perinatology. So I hope with this CME, our viewers and the delegates and the members will be benefited, and they will also enjoy it. So many, many thanks to all of you to attending this program. And once again, I welcome you. And now I invite our Clinical Secretary, Tulika Jha, to start the sessions. Over to Tulika. Please, Tulika, please unmute. Hello, yes.
Okay. Thank you, Ram. Thank you very much for your opening remarks. So now, without further ado, let's move on to the academic program. To chair the first session, I would like to invite three very respected chairpersons. The first is not only my close friend, she was also a batchmate of medical college. And so it's my pleasure to invite Dr. Moushumi De Banerjee, who is a consultant gynecologist, ESI Hospital, Sialda, and she's also the vice president of the Bengal Obs and Gynae Society. She was the organizing secretary of BOGS 43 and the FWCon 2017. She's the honorary secretary of IMA Calcutta branch, and she has had many papers and chapters in various books, and she's also involved in many scientific and training programs and also in different state and national conferences. Welcome, Dr. Moushumi De Banerjee, to this session, to this academic session. Next, it's my honor to invite Professor Narayan Jana as the next chairperson for this session. He has many laurels and achievements to his name. He's the professor and head in Chittaranjan Seva Southern College of Obs and Gynae and Child Health, Kolkata. He's the recipient of the Korean Award, ISUOG Award, CSNA Award. He's been the former vice president and chairperson of the East Zone AICC and member of Project Advisory Group ICMR. He's got various and several publications and chapters in the textbooks, special contributions in tuberculosis in pregnancy and eclampsia. And so welcome, Dr. Jana, to chairing this session. And next, I would like to invite, with great pleasure, and it's my honor to invite our teacher, our respected Dr. Sukumar Bhattacharya, who was the professor and head in Bardhaman Medical College and Hospital. He has also been the professor and head of the department at Eden Hospital at Calcutta Medical College. He has been a former president of the Bengal Obstetric Society and has many publications in national and international journals. So welcome, Dr. Banerjee, Dr. Bhattacharya, and Dr. Jana. The stage is yours, and you can now invite the chair speakers one by one.
Namaskar. Am I audible? Hello.
Yes, sir. Yes, sir.
Yeah. Namaskar. It is a great pleasure and honor for me, along with my co-chairs, to be here to chair this prestigious session, where there is two very eminent, experienced, and dedicated teachers who will present their news, views, and experience with two important topics. One of them is senior to me in PGI, Professor Barik, and one of them is just junior to me, Professor Mandakini Pradhan. So both of them is very close to my friendship circle, and they are very close friends for a long time. Professor Mandakini Pradhan done her MD from PGI Chandigarh, then a DM from SGPGI Lucknow. So in medical genetics, very few obstetrician and gynecologists have this rare experience of medical genetics in depth. And from there, she is now professor and head of maternal and reproductive health. Very unique department. She has created by bits and bits, and created a very important landmark in the Indian scenario. It is a great pleasure to invite Mandakini to this podium to share your unique experience of genetics with us on the topic genetics of fetal loss. Mandakini, Dr. Mandakini, I call you Mandakini because you are very close young junior for a long time with a lot of affection. This is now the stage is yours to present your experience on fetal loss, genetics of fetal loss. Mandakini, please.
Please allow me to share my screen. Thank you, Dr. Jana, for that introduction from the heart. And I'm overwhelmed. That's very few people actually understand what is this maternal and fetal medicine and the role in days to come. So thank you, Bengal Obstetric Society, to call me and to involve my committee for this webinar. And thank you all those who have joined this webinar. Can I share my screen? Actually,
yes, you can. You can.
Yeah, now I can. Yeah.
Yeah.
Okay. So, okay. Next 15 minutes, I'm allowed to, just a minute. Yeah. So next 15 minutes, I'll be covering genetics of fetal loss, because I have got some 36, 38 slides. So few of them I'll be going through very fast. Why it has gone? Yeah. So in which clinical scenario, at least we start thinking, should I know something about genetics? I should have read it. or I need some amount of help, towards the end of my talk, I'll be covering how to get, where to get help. So, but then those clinical scenario are most commonly is recurrent abortion if we see a patient, then congenital malformation, either a baby is born or in the intrauterine life. If there is a fetal death, the cause of which you do not know, and neonatal death. Many of us come across this clinical scenario every day, that there are previous 2 neonatal death, cause is not known. So can it be genetics? So let me come on to the first common clinical scenario, that is recurrent spontaneous abortion. This couple came to us with 5 previous spontaneous abortion, and the the chromosomal analysis, as we know that 3 to 5% cases of couple with recurrent spontaneous abortion will be carrier of chromosomal abnormality. I will elaborate in detail little while. So this couple also had a chromosomal abnormality, and the report says 46. There are 46 chromosome XX. The female is the carrier. T stands for translocation between chromosome 4 and 12. If I understand up to this, then my work is half done, almost done. Clinically, I can manage. And there is a balanced translocation between chromosome 4 and chromosome 12. So what is a balanced chromosomal translocation? Is there is no loss or there is no gain of genetic material, and hence it is called balanced, that nothing is lost, nothing is gained. So it is a balance, though there is some exchange of material, of genetic material has occurred. So balanced chromosomal translocation is seen in 5% cases of recurrent spontaneous abortion. Either the husband or the wife may be a carrier. What will happen to their subsequent pregnancy loss? If I do not go into detail of 4-12 translocation or 4-11 or 3-2 translocation, then as a whole, I can remember that if husband is the carrier, then subsequent pregnancy loss will be 5%. If wife is the carrier, then subsequent pregnancy loss will be 10%. So it is easy for me to remember 5 to 10% risk of subsequent pregnancy loss if one of the couple is a carrier of balanced chromosomal translocation. So here is the same 4-11 translocation that is depicted on the left side of the screen, and there can be the gametes that can be generated from this is a normal 4 or a normal 11 can go onto the gamete. So from the husband or from the other partner, a 4 and 11 will come, and this will result in an absolutely normal gamete. The other thing can happen is that there is the translocation or balanced, both the translocated chromosomes can go on to the gamete and will form a balanced chromosomal, balanced gamete, and will result in a offspring which is similar to the couple, that is one of the couple that is having this carrier. But what will be if there is normal 4 or any combination of it, a normal 11 with abnormal 4 or a 4 with an abnormal 11, or any combination of it that I have made in this red encircled with a red this thing. So this will result in unbalanced gamete formation and will result in fetal loss. So but this risk of having fetal loss is 5 to 10% as I described. But this holds true for these chromosomes which are long enough or have got a centromere in between, and they have got a P arm and a Q arm, or a short arm and a long arm. But what happens if the chromosome are acrocentric? That means they do not have a short arm, or a P arm is not there. So it is only the long arm. Like chromosome 13, 14, 15, these are all acrocentric chromosome. 21, 22 are acrocentric chromosome. So here is a couple who has got a translocation chromosome. The total number of chromosome are 45. It is in the male, that is XY. And T again stands for translocation between 13 and 14. As I told you, 13 and 14 are acrocentric chromosome. So what has happened is, this is a normal 13, a normal 14 has got attached over here in the 13. So we have got 213, actually 214. So there is no loss or gain of genetic material. But while counting, this 13-14 combination is counted as 1, and hence the counting is reduced from 46 to 45. However, it is balanced, and this type of balanced translocation is called as a Robertsonian translocation. So we remember, in Robertsonian translocation, the number of chromosome will be 1 less. Why at all we need to know is, this is a 13-14 translocation, and the gametes will be formed either normal, that normal 13 and 14 to 1 gamete. Say for example 13 and 14, those which is the translocated one into 1 gamete. So this will be resulted in normal gamete and normal pregnancy outcome. However, if there are this 113 and the other chromosome is 13-14 translocated one, so we already have 213 over here, and 113 will come from other partner, so it will result in a trisomy 13. So similarly, a trisomy 14 can be formed, and these will result in, most of the cases will result in pregnancy loss. So hence, in Robertsonian translocation, again the pregnancy outcome is 5 to 10%, as I told you. Here is a couple who had this lady had come to us after following 2 abortions, and before her 3rd pregnancy, in fact, and she was found to be a carrier of balanced 13-14 translocation. During her 3rd pregnancy, we did the amniocentesis, we did the chromosomal analysis. The baby was found to be carrier of chromosomal translocation 13-14, and we explained them that the outcome will be same as that of the mother, continued the pregnancy, and they have a healthy baby. Now again, in 4th pregnancy, we did a amniocentesis, and it resulted in a 46 normal chromosome. So what I explained you is, it can be 13-14, this 13-14 can go to 1 gamete, and in this family, in 4th pregnancy, because of that, it resulted in a normal gamete. So, but on taking history, we realized that she had a monozygotic twin sister, and by that time she was pregnant. And we naturally know that if she is a carrier, the twin sister will be a carrier of Robertsonian translocation, and her pregnancy was also tested and was found to be normal. So luckily they had, both the sister had normal outcome. But why should we know at all? What will happen if the chromosomal, till now we discussed about different chromosome. It involves 13-14. Now let's come on to same chromosome, that is 20 and 21, or say 13-13. Here the Robertsonian translocation between chromosome 13 and 13. Here between 21 and 21. So we have 45 chromosome, Robertsonian translocation 21-21. Now what will happen to the gametes? If you remember, then either this 21-21 combined will go to 1 gamete, or a gamete may so happen that it will not receive any of the 21. So what will happen is a monosomy 21, and then it will result in spontaneous abortion. But here there are 2 21 already and 1 from other couple, so it will result in trisomy 21. So what will happen? This person will never have a normal pregnancy. So hence 100% risk of recurrence if it involves both the chromosomes which are same. So there will be 100% recurrence of either monosomy 21 or trisomy 21, and hence this couple is advised for a donor gamete. Like translocated trisomy 21 was found on the same person had a pregnancy and was found to have a trisomy 21, which is translocated 21. Pregnancy terminated. We actually in fact advised for donor gamete without informing any of the family member. They had a twin normal pregnancy. Similar to this is a husband who is carrier of Robertsonian 13-13. All pregnancy either will be monosomy 13 and hence aborted, or trisomy 13 and hence you will see multiple malformation in those fetus. Here you will have a gamete donation either in the form of IUI or in the form of IVF. So how do you deal with these patients? Recurrent spontaneous abortion, carrier of chromosomal translocation, reassurance. As I told you, 5% or 10% risk of pregnancy loss. Monitor early pregnancy. Prenatal diagnosis is possible, as I explained in one of the case. It may be CVS, early gestation, or amniocentesis, late gestation. I'm not going into detail of it. Use of donor gametes if same chromosome translocation is found out. So if, remember that if it is 21-21, it is gamete donation. So similarly, you will find in the product of conception trisomy 13, trisomy 18, trisomy 14, trisomy 22. So any trisomy can occur in product of conception. Any other cause of pregnancy loss? Another major cause is inherited thrombophilia. And many of us probably know that the inherited thrombophilias that are responsible are protein C, proteinase deficiency, then factor V laden mutation, then MTHFR and antithrombin 3 deficiency. Not going into detail of it, MTHFR and antithrombin 3 are not very statistically significant factor and hence not recommended by various bodies to be tested in a patient of recurrent spontaneous abortion. What is left behind is factor V laden mutation, specifically in those who have history of thromboembolism. Meta-analysis shows that yes, factor V laden mutation increases the risk of recurrent spontaneous abortion and it should be done. If a patient is found to have factor V laden mutation, the treatment is ecosprin and heparin as we give in antiphospholipid antibody syndrome. So we need to test it. It is an autosomal dominant condition. Hence, one of the parent may be a carrier and we take a history of abruptio in the mother if mother seems to be a carrier. Now, I am coming on to fetal abnormality that are detected and we start thinking about genetics. Here is a fetus, quite obvious, is hydrocephalus or the dilated lateral ventricle and the dilatation is too much. I look into little detail into the anatomy as recommended for any malformation. Single malformation, look for other malformation. What I found is a 4 fingers over here, 2, 3, 4, 5, and the thumb is adducted or it is adducted thumb. That is a very close look at it and see what happened to this child when the child was born. And on the zoom photograph, the child has got adducted thumb. So my diagnosis of hydrocephalus with adducted thumb is now X-linked hydrocephalus. It is a male fetus. Hydrocephalus has various etiology. If I am finding in a male fetus adducted thumb, then I start thinking of X-linked hydrocephalus and it is because of L-CAM mutation. How it is helpful to me is I ask the lab to look for only L-CAM mutation because of my finding. So the finding will reduce the cost of testing in my patient. Risk of recurrence is 50% in male. I can do a prenatal diagnosis if L-CAM mutation is identified previously and I do a CVS at 12 weeks. Exactly that was done in this patient and had a normal baby. See this photograph. Patient may have photograph. This was very old photograph of one of my patients almost 10 years, 15 years back. What I can make out is from this photograph is the baby has got Porter's facies and a enlarged abdomen. And what I did that time, the ultrasound quality was like this and I found the kidneys were enlarged and delivered this that pregnancy, the subsequent pregnancy. And what did I find on cut-open? Cut-open, both the kidneys were enlarged and it was spongy, very tiny cysts were seen. And subsequent pregnancy at 12 weeks, we could able to find out that the kidneys were enlarged and we terminated those pregnancies. Subsequently, of course, this patient, and this is autosomal recessive polycystic kidney. And as the name suggests, it is autosomal recessive and hence 25% risk of recurrence. And subsequent pregnancy can be looked into by seeing into the ultrasound or you can have a molecular testing as available these days. So you can diagnose it. This couple had 2 subsequent pregnancy which were normal. Sometimes you need to examine the previous child. And here is, see this pedigree. There were 3 affected. One of them has died. 2 are living, 1 male and female. So I start thinking about something and a consanguineous couple. I start thinking male female affected, so it could be autosomal recessive. Examination of the previous child. See, one child has died. This is the second child. The third one got operated by a neurosurgeon. Great. And see this child, and this child is hanging this thing. It is encephalocele. On closer look, the baby has got polydactyly, and this is polydactyly seal. Polydactyly encephalocele, if you give in your this thing Google or anywhere, you will find Meckel-Gruber syndrome is the cause. It is autosomal recessive. Molecular diagnosis is possible, and prenatal diagnosis can be done by CBS. Of course, Western literature will say CBS if molecular testing is done. But in India, what I did personally for this patient is at 12 weeks, I looked for encephalocele, and subsequently pregnancy continued. Sometimes in intrauterine life, you see some cardiac tumor, examine the parents, and one of the parent was found to have adenoma sebaceum. Subsequently, the MRI showed some tuberous, and it is an autosomal dominant condition. Another patient referred to us as intracardiac echogenic foci. This is not intracardiac echogenic foci. This is a huge ball inside the heart, and this is cardiac tumor. Subsequently, this was because 36 weeks, 2 days, this patient came to us. So we did allow the baby to deliver, and after delivery, we did the molecular analysis. So how it helps is, it directly I'm sending the sample for tuberous sclerosis mutation analysis. And the cost to the patient decreases, the expenditure to the lab decreases. Say, with this history of previous 2 pregnancy loss because of polyhydramnios, less fetal movement, CTEB, I started examining this woman. No, because of this reason, I have not shown the face, but if you have a closer look, then you can see that there is expressionless face, or what is called as a myopathic facies, and can demonstrate myotonia, and the diagnosis is myotonic dystrophy. Another family, just recently during COVID, just before COVID, we did see it, and she delivered unfortunately during COVID. This is the patient, that is this patient. I'm showing it because I've taken consent for showing this. And on this patient came to us with polyhydramnios, referred as polyhydramnios. Both her previous pregnancy was affected. In fact, when she came, she was pregnant, and now she has delivered. And this baby again delivered by cesarean section and did not survive. And on closer examination, we did ask about a detailed history. Her brother has got muscle weakness. This is the brother photograph. Then her mother had a pacemaker, this thing, most likely cardiac heart block. And her maternal uncle, that is, had early onset cataract. So all these points towards myotonic dystrophy. And see, when she is shaking hand, and what is happening is she is unable to release it. This is simply, you can do it, and then know that it is myotonic dystrophy. It can present with polyhydramnios, and congenital myotonic dystrophy will have fetal death. So this can result in pregnancy loss. So going on to the next case, sometimes we see such type of a history, that recurrent male death. So all of us in our practice have come across conditions like recurrent male death, and then female. Say for example, this family had some female, one female who is alive. See, closer look at the female, has got some vesicular eruption in the early childhood, 6 months of life, and then all those rashes, the scar mark is left behind. And seeing these rashes, as an obstetrician, I will start thinking it is probably herpes infection in the early childhood. But see, the examination of the teeth, she has got single incisor, and her mother also had got single incisor. So this is a condition which is X-linked dominant and is called incontinentia pigmenti, where such type of feature is seen. So as it is just to emphasize that if you were getting a history of males being dying, then we must think of X-linked condition. One slide. Yeah.
Mandakini.
Yes.
Please now summarize.
Yeah.
Okay.
Okay. So let me summarize the case that going on to the okay. this was interesting that however, all recurrent pregnancy loss is not genetic. Sometimes you see some condition like this, and this is pemphigoid gestationalis. This is immunological, and if you go ahead and start her on steroid, then this condition relieves and you get a live birth. What is done in this case? So she had a live born baby. So what is approach to genetic cause of pregnancy loss? As I said, first trimester chromosomal analysis of the couple. If you find abnormality, then 5 to 10% of pregnancy loss. But the other way around is most of them will have a normal pregnancy outcome. Fetal malformation, either single or multiple, you need to see. And any malformation, now the recommendation is microarray examination. DNA can be kept for sequencing if we suspect any other syndrome. Multiple malformation fitting into a syndrome, a targeted mutation analysis can be done. But how do we diagnose a syndrome? Either I myself know about it, I can phone a friend, or now this Mail to Genetics and Fetal Medicine Committee of FOGSI, which has opened up a helpline, whereby is receiving any difficult case, so that the committee members are solving it and then sending you back in 72 hours. So that's my commitment to FOGSI. Or you can take online assistance like online Mendelian inheritance in man, that is OMIM, or London Medical Database that I usually use, or you can have a POSOM web. For London Medical Database, it is some $10 per month. Yes, and POSOM is $300 for a year. Something is there, so you need to buy it and then look into it. You get online assistance in this. So together we can serve our patient better. To assist you, the FOGSI, the helpline is mpradhan9918@gmail.com. This is the helpline Gmail that I have created, so that the member of this my committee, that is Genetics and Fetal Medicine Committee of FOGSI, will solve your case and refer it back to you, so that we enrich ourselves. I again thank all of you to have a patient hearing and giving me a chance to share some of my cases and some of the thoughts. I'll be happy to clarify any doubts, if any. So thank you so much, and thank you, Bengal Obstetric Society.
Thank
and
you.
I look forward for the other talks also.
Yeah.
Yeah.
Thank you, Dr. Mandakini, for your excellent presentation with clinical examples. And we'll come back to you once again with question and answer. And now we'll proceed for the next talk, which will be delivered by Professor Barik. May I request my co-chairperson to introduce Professor Barik. My co-chairperson, please.
Hello.
Hello.
Yes, should I?
मौसमी डॉक्टर पार्थो भट्टाचार्य के अच्छा ठहर बोल है
अच्छा डॉक्टर पार्थो भट्टाचार्य हाँ सर आपने बोलूं
Sir, please unmute. Yes, thank you.
Yes. Dr. Sukumar Barik is a professor and HOD Eye Care Science and Research Kolkata Western, and he is also the East Zone Chairperson, ISOPAR, examiner in MBBS and MD, published over 50 articles in national and international journals, delivered several orations, many more guest lectures, received several national awards for presentation, and also is a peer reviewer of International Journal of Obstetrics and Gynaecology, British Journal of Obstetrics and Gynaecology, and of course, FOGSI Journal. And special interest is reproductive endocrinology, fetal monitoring, and high-risk pregnancy. Now, I may just add on a personal note, he's very much noted for his plain speaking, and I'm sure he will deliver a very straightforward lecture this afternoon. Well, Dr. Sukumar Barik, the floor is yours.
Am I audible?
Yes, you are.
Thank you very much for your kind introduction. Respected chairpersons, distinguished delegates, ladies and gentlemen. I think our topic is very simple, day-to-day, basic topic of antenatal corticosteroid, the controversies and the consensus. Fortunately, the controversy is the hallmark of any the healthy society. And because the consensus is only generated only when there is controversies. And what our secretary has told, you have discussed the controversy and you give the answer, give the consensus. Though there is no discussion, because I will ask the questions and I will ask the answers as well. So ladies and gentlemen, why we are considering antenatal corticosteroid? Because we understood by this time that 34% reduction of respiratory distress syndrome, that is about 46% reduction in the intraventricular hemorrhage. There is about half of reduction in necrotizing enterocolitis, and overall mortality is reduced by 1/3. But to reach this conclusion, the story is about half a century story is there. Ladies and gentlemen, this is a gentleman who did some experiment in the sheep in 1969, then published this article in 1972 in a esteemed journal in Pediatrics, and is a controlled trial of antepartum corticosteroid treatment for the prevention and of the respiratory distress syndrome in premature infants. It was so simple. We are in school at that point of time, but MBBS curriculum goes, the postgraduate curriculum goes, and then in 1990, when we are appearing for the MRCOG exam, it suddenly appeared, people awakened up and said, effects of corticosteroid published in BJOG, and then the rest of the things took very slowly picked up over the globe. And 2004, ladies and gentlemen, if you look at the RCOG document, it shows antenatal corticosteroid to prevent respiratory distress syndrome. Next, another 2010, the name changed. The antenatal corticosteroid to reduce neonatal mortality and morbidity. So ladies and gentlemen, subsequently, now if you search, the RCOG document is now moved towards a nice guideline, and there are publications, and this is a very important document. I will request all of you to look at. This is the FIGO document of good practice guideline or good practice advice and of antenatal corticosteroid for fetal lung maturation. So if we at the current moment, it's very clear that one group is definitely going to receive this one, and so between 24 to 34 weeks, there is no doubt that we should offer a single course, not the dose, I'm mentioning the course of antenatal corticosteroid. And we know that if the gestation is less than 24 weeks, then we have to discuss with the family's decision, because we have to consider the threshold of viability. We may consider that in our country, maybe slightly more, maybe 26 weeks or so. But what happens? So 24 to 34 solved. What happens if it is between 34 and 36 plus 6, means we are 37? Should we give antenatal corticosteroid? Ladies and gentlemen, there is an article published in New England Journal of Medicine in 2016 showing administration of betamethasone when at risk of late preterm delivery significantly reduced the rate of neonatal respiratory complications. So we extend from 24 to 34 to 34 to nearly 37 weeks, we extend. Now, yes, this is the recommendation. As I mentioned, recommendation from FIGO, and SEOG to extend from 34 to nearly 37 weeks. So it's very clear at the current moment, it is not up to 34 weeks, it is up to nearly 37 weeks. So what happens if somebody has got higher elective cesarean section? The lot of cases we do between 37 and 38 plus 6. As you understand, the RCOG document and the recommendation at the current moment is to do the elective cesarean section at or beyond 39 weeks or around 39 weeks rather than 38 weeks. So this is now an accepted thing. But what happens if we do elective cesarean section between 37 and 38 plus 6 weeks? Look at this document, which shows published in BMJ in 2005, clearly shows that this practice, if you give antenatal corticosteroids before elective cesarean section, even in the mother who is between 37 weeks to 38 plus 6 weeks, will reduce the respiratory system by more than 50%. That means if it is extended towards 39 weeks. So ladies and gentlemen, this is the FIGO document in 2019. It suggests consider antenatal corticosteroid between 37 weeks and 38 plus 6, particularly when there is a medical. So you have to consider doing elective cesarean section beforehand, but probably it is beneficial to give the antenatal corticosteroid. There are special situations, and special situation like multiple pregnancy. In that case, there is a nice, this is a document published in American College, which shows probably it is a good idea to give this thing antenatal corticosteroid, particularly if it is delivered between 37 weeks, because the twin pregnancy, many of them probably doesn't go beyond that thing, and it is recommended to give this thing, but the clear-cut benefit is still not there, but it is recommended. So one course of antenatal corticosteroid to all women with between 24 to 30 weeks, irrespective of so whether it is singleton or it is a multiple gestation. What about if it is GDM or diabetes mellitus, whether it is type 1 or type 2, it is recommended to give this antenatal corticosteroid. Ladies and gentlemen, we know that if somebody is receiving additional insulin, we should be particularly careful to give this one, simply because the dose of insulin needs adjustment when you give this the antenatal corticosteroid. Many of us admit those. If you do elective cesarean section, we admit them day before and give the antenatal corticosteroid, adjust the dose of insulin so that it is optimized. So what happens about the controversy about the repeated course? Ladies and gentlemen, this is one of the fantastic articles published in 2007 in NEJM. And surprisingly, in the same day, there are 2 articles. And in the same day, in the clinical meeting, we discussed these 2 articles, which produces completely different stories. This article was published from United States, USA, and this shows the long-term outcomes after repeat antenatal corticosteroid stage, repeated dose. That means what they have done weekly antenatal corticosteroid, and what they have found, repeat doses of corticosteroid, there is a concern about increased cerebral palsy. This is a study published from States. The same journal published another article, same day. It is from New Zealand by the Caroline Crowther group, shows administration of a repeated dose does not change anything, neither neurological disability or any other baby size after 2 years of follow-up. So ladies and gentlemen, there are 2 contradictory papers published in 2007, but that makes us very cautious, and at the current moment, both FIGO and SCOG guidelines suggest we should not give regularly repeated doses, and only thing we can consider is a rescue course if it is at all needed, which is the next course, that is rescue course. That means a single repeat course of antenatal corticosteroid when you are expecting that delivery to happen within next 7 days. And the first one, the dose was given less than 34 weeks gestation, and the time has elapsed more than 2 weeks. In that case, you may consider giving a rescue course and no repeated course of antenatal corticosteroid. So that is the last controversy, is what to give. We know the most of the people or most of the guidelines suggest that butamethasone and dexamethasone both are fine at the current moment. But this is one of the documents published in June 2014. Mainly it is for the ANM, the midwives, which suggests that in India, the salt butamethasone acetate plus phosphate, which requires 2 days, are not available. What is available in our country is betamethasone phosphate, and this is the reason why they suggest that the best thing is probably to dexamethasone, because it is more stable and less costly. But ladies and gentlemen, at the current moment, jury is out about this thing. Although this suggestion is from the Indian guidelines, many of us and many guidelines suggest whatever available, you have to give antenatal corticosteroid in appropriate time. So you have to offer all cases of single course of antenatal corticosteroid between 24 to 34 weeks. So it is a consensus, no controversy in this area. You should consider single course of antenatal corticosteroid between 34 and 37 weeks, 36 plus 6. So we have extended this one from 24 to 37 weeks. And even if you are going for elective season section, you may extend that one to about 39 weeks. That means 37 and 38 per 6, we should consider antenatal corticosteroid. I have already mentioned that better to consider single course of antenatal corticosteroid between 24 to 34 weeks, particularly in multiple pregnancy, in diabetes mellitus, or even gestational diabetes mellitus. So when we should not give repeated course of antenatal corticosteroid, this is not needed at the current moment. It may cause some harm, so it is not recommended, but we can consider a single repeat dose, which is known as a rescue course. I usually don't say dose, better to say course of antenatal corticosteroid, where the birth is expected within 7 days, and the first course was given before 34 weeks, and the time has elapsed, at least 2 weeks has passed, and in that course, you can, in that case, you can consider giving a rescue course. So ladies and gentlemen, betamethasone or dexamethasone, both can be used, but we should be aware of the fact that at the current moment, the Indian guidelines prefer dexamethasone. However, WHO also prefer dexamethasone. But having said that, dexamethasone and betamethasone probably has got the same efficacy at the current moment. So at the end, I want to say the antenatal corticosteroid is one of the greatest examples of a simple intervention creating a huge impact in perinatology, ladies and gentlemen. So think simple rather than thinking big thing and implementing that one, because this is an example which took 50 years to come down to the practice, and still now, if you audit somewhere we miss some time. So thank you very much for your kind attention.
Thank you, Dr. Barik, for excellent presentation. Now, may I invite now Dr. Mousumi.
Mousumi?
Yeah, thank you, sir. It was, we were going through excellent presentation. especially Dr. Mandakini Pradhan. She presented wonderfully and so lucidly, and no exception from Dr. Sukumar Barik. Sir is always excellent, Sukumar. Now, I have a question for Dr. Sukumar Barik. When you find that there is imminent signs of chorioamnionitis, do you and you have to deliver the patient, do you advocate giving of a rescue course of this? A single dose of this corticosteroids?
I think one of the contraindication, if you definitely suspect chorioamnionitis, this is one of the strong contraindication for not so contraindication or anterior. So we shouldn't give it if you strongly suspect chorioamnionitis. It is one of the contraindications.
But when there is just tachycardia, or it is just, it's entering into the state of chorioamnionitis at the initial state, when you going to deliver the baby in emergency, then do you give a single dose?
The single dose means at any point of time, you can give a dose even if you are expecting a delivery within 2 hours. So there is no harm. But your question is, if you are considered thinking that it is chorioamnionitis and you are strongly suspected, we should not give steroid.
Okay.
Moshumi, there are
There is
more
one
questions in the
question.
chat box also.
There is one question in the chat box. The same question, that is there any role of
Hello. Moshumi?
If Moshumi is not, then Tulika, you can read.
There are quite a few questions for both the speakers.
Please.
Moshumi, are you there? No, then I'll put the question. There's one question from Dr. Moinak Nath. I think it is for Sukumar Da.
Yes.
Respected sir, in case of an imminent preterm delivery, is there any role of single dose betamethasone?
Yes, that was the question. Yeah.
I have already mentioned that if you have got time for the both courses, fine. If you don't have time, please don't hold. Whatever it is, you give one. If there is no strong contraindication, even if you have to be expecting delivery within 2 hours, please give it.
Okay. Moshmi, the other questions you can deal.
Yeah. From Amit Basu to Dr. Sukumar Barik, why is it 36 plus 6 and 38 plus 6 instead of 37 and 39?
These are all juggleries of obstetrics, you know. As you know, Amit, that these are juggleries. Why not saying 34 plus 4, 34 plus 6 rather than 35? You understand what it means. That it is extended, people are extending from 34 weeks to nearly 37 weeks. And for elective section from 37 to nearly 39 weeks. So these are juggleries. There is no difference of these things, really, in practical sense. When you have to write a guideline, you have to write like that, you know.
So any more questions from the floor or the...
Yes, Moshmi, I think, see in the box, there are questions in the chat box and the Q&A box from Mandakini ma'am also.
Yeah, can I read it?
It is from Sanjay Prasad
Yes,
Gupta.
ma'am, you can read her.
Yeah, somebody wants to, Dr. Sanjay Prasad Gupta. He wants to know previous 2 abortion, 3rd pregnancy, NT scan double marker normal, anomaly scan shows lower limb, bones thin and bent. What to do next? It could be because of, like what you describe is most likely it is skeletal dysplasias. As an obstetrician, how do I remember all those? This thing is, if you describe your finding that this femur is bent, both femur is bent, both are equally bent, femur along with tibia and fibula are short, this is 2nd percentile of the normal, less than 5th percentile of the normal, it becomes more clear. Second is, if you can't do this, still you can do, this fetus is likely to be affected. with skeletal, one of those skeletal dysplasias. How do you diagnose it? Is sending one sample, fetal sample. It could be cord blood, it could be amniotic fluid, it could be CBS, to the lab for exome sequencing for skeletal dysplasias. That will cover a long list of skeletal dysplasias, and they will look into the mutation and will get back to you. Okay.
There is another question from
Dr. Sanjay.
Yeah. Is there any side effect of corticosteroid to fetus? Yeah.
I have already mentioned that one. There are 2 studies of long-term follow-up published in NEJM in 2007, and there is another article also published so far. I have already discussed about the contradiction about the repeated one, but so far the follow-up of standard doses are very reassuring, and that is the reason why they have come to the conclusion of giving this thing universally. So repeated dose, no. Rescue dose, yes, you can consider, but imminent, like there was one, I think I can see in the chat box, a fantastic one from Suparna, that giving, if you are thinking about, if you are thinking about imminent delivery, should we give 24 milligram at a time? I think the recommendation is not 24 milligram at a time. You may expect that if you give more, it will be better. No, it's not recommended. You give 12 milligram, and if it delivers, fine. But if you give some time later on, then you give 12 milligram again after 12 hours time. You can cut down from 24 hours to 12 hours the gap. That is probably a good practice. Many people practices like that, but not 24 milligram at a time.
I think there is a question from Devoshmita also for Dr. Pradhan. Moshmi, you can see in the chat box, not the Q&A box, the chat box.
Yes.
Regarding spinal muscular dystrophy.
I am unable to.
The question is, the question is couple carrier screening necessary where we are getting a positive history from father pedigree in the case of spinal muscular dystrophy?
Yes, it is essential. It's a very common disease. We find very commonly, and prenatal diagnosis is possible, can be preventable, so it should be done. And carrier screening by mutation analysis, not by any other test, little difficult, little costly, but then should be done for the couple. If there is family history, definitely yes.
And what is the solution, ma'am? What you are telling about the solution, how it is preventable?
It is the risk of recurrence is 25%. As in thalassemia, sickle cell disease, all autosomal recessive conditions. How do we prevent it? We do a CBS at 12 weeks. Send this sample for the specific disease that we are looking for. Say, for example, in this case, we'll send the sample for looking for spinal muscular atrophy mutation analysis. Now, the lab will tell you if the fetus is affected or not affected. If affected, then you terminate this pregnancy, which is likely to be in 25% of cases. And in 75%, either you get a carrier or a normal fetus and you continue those pregnancies. Okay. So you can prevent birth of a spinal muscular atrophy babies. And for all those who are listening, how do you take a history of spinal muscular atrophy is if there is history of baby dying early childhood with respiratory distress.
Yeah.
All of us keep on saying meconium aspiration. It is not that.
Exactly.
If the cry is very weak, and specifically if somebody says that from this room, the cry was not heard in the other room. So then this is most likely spinal muscular atrophy. From history only, we have diagnosed many families carrier of spinal muscular atrophy.
Is there any role of gamete donation? Gamete donation?
No, not gamete donation. 75% normal, please.
Normal. Okay.
Gamete donation, 21 translocation. That's the only thing.
Okay.
Okay, Moshmi, I think we need to wrap up because we are running. There are plenty of questions, but time is short for answering every question. Yeah, Narendra, please continue.
Yes, it is now the time to conclude the session. On behalf of the chairperson, we are grateful, honored to chair this session. Thanks for the great job done by the two speakers. And many, many thanks to the attendant and all participants who have put their questions, show their interest in this program. And finally, our thanks to the BOGS to invite us to chair this session. Thank you very much.
Yes, thanks a lot. It was a wonderful session. Thanks to BOGS to be a part of it.
Thank you.
Thank you very much.
Thank you, respected chairpersons, for a very interactive and interesting session. And thank you, Dr. Pradhan and Dr. Barik, for making it so interesting. Dr. Mandakini Pradhan, you made the difficult subject of genetics look really easy. And Dr. Barik, you also cleared all doubts which we had regarding antenatal corticosteroids. Thank you very much.
Thank you. Thank you.
So we move on to the next part of the program. And in this, I would like to welcome our president, Dr. Bhaskar Pal, to deliver his welcome address for the participants and the faculty members of the seminar. Welcome, Bhaskar Da.
Thank you, Tulika. It is not a presidential address. I don't want to address
No,
it.
well,
It's just my way of giving my attendance that I have been present and I have been listening. Many thanks to our chairpersons and to our two speakers, especially Dr. Mandakini Pradhan, chairperson of the Genetics and Fetal Medicine Committee of FOGSI, for collaborating with BOGS for this program. And we could not take all the questions because of the paucity of time, but I would request Dr. Barik and Dr. Pradhan you can answer the questions live on the Q&A panel, which is on the extreme right below, and everybody else can read that while we get along with the program. I hope all of you have got vaccinated, and we are really looking forward to resuming our physical interactions, but I have a feeling the virtual meetings would not go away. So whenever we resume physical meetings, we will possibly be looking at one virtual and one physical a month to start with. But at the present moment, fingers crossed that let's hope that any part of India doesn't get hit by a second wave, and we can resume physical interactions maybe in the month of, in 1 or 2 months' time. I thank all of you for participating in this program, and we look forward to a very interactive and interesting panel discussion. I understand that today's subjects have been pretty difficult, and corticosteroids is not necessarily a difficult subject, but there are so many controversies about which one to use, and especially with the new studies coming in, putting some doubts in people's mind. So it's been a difficult one, but we have a very interactive audience which we can make out from the number of questions we have. So thank you very much for joining, and we would like to see you again on our next program, which is on the 27th of this month. Thank you very much, Tulika. Tulika, you're muted. Tulika, you're muted.
Thank you, Bhaskar Da. And taking a cue from what Bhaskar Da just said, yes, we have another CME on infertility this time on 27th February from most probably from 5:30 p.m. It's a Saturday. So please block your date and time, and I'm sure it'll again be an interesting session because we have wonderful speakers and interesting topics as well. Now, I would like to invite our moderator for the evening, my friend, and also the Joint Clinical Secretary of our society, Dr. Sita Ramamurthy Pal, to begin the panel discussion on the topic Intrauterine Infections, Perinatal Outcomes. Over to you, Sita.
Thank you, Tulika. Thank you. After those wonderful talks by Dr. Pradhan and Dr. Barik, we now move on to a very intimidating topic, I might say. When I was myself given the onus to moderate this session, I too was getting intimidated, but I'll try and make it as simple as possible. Before I share my screen, I would like to be shown the CVs of my esteemed panelists. So we have with us a mixture of fetal medicine specialists and obstetric consultants and a neonatologist and a pediatrician, so that we have a multidisciplinary approach about everything that we see as we should normally do in our day-to-day practice. So our first panelist for the day is Dr. Alpana Chetri. She's Associate Professor at the CSS College of Obs and Gynae and Child Health and Managing Committee member, very active member of our Bengal Obstetric Society. Welcome, Alpana. Next is Dr. Bijon Shaha. He's, as I said, a neonatologist, an associate professor, Department of Neonatology at the IPGMR and SSKM Hospital, Kolkata. Welcome, Dr. Shaha. Next, we have Professor Dr. Devashmita Mandal, who's an obstetrician and a fetal medicine consultant. She has a huge CV. I'm not going to read the whole part of it, but right now she's a secretary in the fetal medicine division, a fetal medicine consultant at IPGMR. She works as a fetal medicine consultant at birth, has a number of papers to her credit, and she's also now the executive board member for the Society of Fetal Medicine. Welcome, Devashmita. Next, we have our own, my dear friend, Dr. Kanchan Mukherjee, who's a consultant fetal medicine, Apollo Hospital, Kolkata, and he's also the honorary secretary of our Society of Fetal Medicine, Kolkata chapter. He's been a very active faculty in various international and national conferences and has a lot of papers published to his credit. Welcome, Kanchan. And finally, we have our esteemed obstetrician and very experienced Dr. Rajiv Dhal. He's a consultant obstetrics and gynecology at the Peerless Hospital and Research Center, Kolkata. So once again, welcoming all our panelists, and I'll move on to my sharing my screen. Yeah. So can you all see my screen and can you all see my arrow? Yes. Okay. So basically, we're going to be talking about intrauterine infections. And as again, welcome all my experts here. And we would like all my valuable inputs from all our experts here. So before I start anything, I would like to make a note of where I have taken all my data and references from. This is the latest on the ISUOG, which is our Bible for fetal medicine, the International Society of Ultrasound of Obstetrics and Gynecology, where they have published the guidelines in May 2020 about congenital infections, the Journal of Society of Fetal Medicine in March 2020, NACO guidelines, of course, and also the Australasian Society for Infectious Diseases. So when we talk about infections in pregnancy, they can be classified into either predominantly maternal, where we see a lot of influenza, dengue, then predominantly fetal, where though we talk mainly about torch, we should also be adding parvovirus and varicella, because that too comes in our armamentarium. And sometimes they can be both maternal and fetal, like HIV and hepatitis infections. Of course, it is not possible to discuss all of them. So hopefully we will try and discuss about 4 cases and pertinent issues which really confuse us regarding these infections in pregnancy. A very important thing to note is most of these viral illnesses may be symptomatic only in 5% of women, and majority are clinically silent, and they can be either primary or secondary. To set the ball rolling, Alpana, can I ask you, why are we so worried about, why are we so vague about our infections in pregnancy? What are the issues that we need to deal with?
Good evening, everybody. As you've already said, the number of patients presenting with actual symptoms are around 5%. So it is true, because how many of us taken in account of this type of symptoms, and sometimes even ignore them, thinking that it's a common symptom during pregnancy. So by the time overt symptoms occur, the damage has already been done. And it may so even happen that we go retrospectively after finding on ultrasonography that there might be certain changes in the fetus itself.
Absolutely.
So,
yeah.
So there is some sort of underdiagnosis of these infections.
And of course, sometimes the serology can be so confusing, and we're not very clear about what's happening. So let's hope this panel makes things more clearer after that. So Dr. Rajiv Dhal, what do you think about how do we, whenever an infection is suspected in the mother, any sort of infection, how do we go about diagnosing infections in these pregnant women?
Hello, thank you, Dr. Sita. Can you hear me?
Yeah, we can.
Yeah. Thanks for the question. Now, the first thing we must understand is that, we should not confine ourselves to just viral infections. We also have to consider about bacterial infections and parasitic infections, like Toxoplasma is a parasite. But since we are talking mostly about viral infections, we must not lose sight of COVID also, which is also a viral infection. So that should also come into the gamut of our discussion. Now, diagnosis of these infections, may be quite straightforward in most cases, but it can also be challenging. Like in certain cases, just by doing an ultrasound, for the anomaly of the fetals, we're looking for anomalies in the fetus, if you detect some telltale signs of congenital abnormalities in the fetus, you can retrospectively think that the mother might have had some infection. Sometimes it's so challenging, but usually it's straightforward, because if you take a simple, comprehensive history, you can arrive at a diagnosis in most of the cases. Like if you take a general history, like a history of fever or a malaise or glandular.
But sometimes they
enlargement.
might be very non-specific. So how do you
Yeah.
go about diagnosing maternal infection in these women?
Like, after you have taken a complete thorough history, if you do some, if you are thinking about laboratory investigations, then you have to first think about blood investigations, like, simple investigations like routine CBC, and then, some serological markers for, you've got serological markers for various diseases. Like, it will be targeted according to what infection you are suspecting. So if you're suspecting, if you're suspecting rubella, that will be apparent from the history, what sort of serological test you want to do.
True.
And
so usually when we're looking at maternal infections, diagnosing infections, as he rightly said, it depends on what we are suspecting. So, but if there are viral infections, then we look at ELISA and we look at these serological markers, which are basically paired serology testing for immunoglobulin M and G. And you have to look for seroconversion, whether the mother is converting her serology during the pregnancy, and what are her titers. And that is why in the West, when they sometimes do these tests, they always save the booking sample. So suppose you sometimes diagnose the infection later in pregnancy or suspect, you can go back and check whether the booking sample had this problem or not. So usually the samples are saved, which is usually not done in our laboratories. And we'll come to antibody avidity testing. So the next question goes to Dr. Kanchan Mukherjee. So when we talk about viral infections and everybody talks about avidity testing, what do you actually mean by this?
Well, once we know from the maternal paired serum that there has been an infection, we want to time that infection, how old that infection is. And a relatively inexpensive but very helpful test, rather underused, I would say, is avidity testing. Avidity testing actually tests how avidly the antigen is bound to the antibody. Now, if there is high avidity, that means that's a past infection. If it is low avidity, that's a recent infection. And that past and old and recent infection is basically 3 months.
3 months. Yeah. So for the general guideline, we take it as 3 months. So anything easy to remember, low is less. So if it's low avidity, it means that the infection has occurred in less than 3 months. And if it's high avidity, it's more than 3 months. So this can sort of filter our screening protocols to a much more sensitive way of approaching these patients. So Debashmita, as Alpana said, that most of the times we sort of go retrospectively, but depending on what we find. So what are the common ultrasound signs of fetal infection that we see in most of these babies who get infected?
Exactly. Actually, this ultrasound signs of fetal infection has been divided according to the which type of infections as well, basically, because one of the infection is very much common, that is CME. So it has been divided according to the cranial, extracranial, and placental that you have already showed in the slide. And this cranial the signs that we see, usually majorly we are seeing actually ventriculomegaly, that we commonly encounter in our OPDs, basically. And calcifications also we tend to occur, and intraventricular synecdoche in between the ventricles. Periventricular cysts can occur, or cortical malformations, that is lesioncephaly, absence of sulci gyri, those things will be there. And the major things that is more rare, but microcephaly do happen also. So these are the things we can. And extracranial findings, many kinds of calcifications, hyperechoic bowel, hepatosplenomegaly, ascites, hydrops basically, pericardial effusion, and as well as other kinds of things like ascites, fetal ascites that commonly occurs basically. And placental findings, those are placentomegaly, and poly sequence can happen. More commonly it is poly, actually we tend to find out, and as well placental calcification. Calcification is one of the things that can happen.
Yeah. So as we are saying, there are a lot of findings, of course, but for a day-to-day practitioner, for a day-to-day ultrasonographist who's done, most commonly seen subtle anomalies is ventriculomegaly, which is easily picked up. These things like periventricular pseudosis, cortical malformations are actually, they need much more detailed scan. And if you see a small for gestational age with polyhydramnios, that itself also should be an indication that this baby might be having an infection. Okay. So Dr. Bijon, for your input, how often do you see babies who are diagnosed with infections after birth? I mean, we try our best to diagnose before birth, but I'm sure when it comes to you, what is your incidence that you notice now with these babies who are diagnosed after birth?
Thank you, Sita. Actually, I was going to the data of my hospital. Been working in a tertiary care hospital, one of the biggest units in this country. So I was going to the last 5 years data, and it is happy to see, because I was fortunate to see all these impacts. Our prevalence will be around 20 to 24 babies per 1,000 of data. And if you see the incidence of infection in the SNC or neonatal carrying the prenatal infection is around 2.09%. And among these 2.09%, what we saw in our data is uncovered incubation process. Concentration around 0.61%. We got mother with HIV positive mother around 0.26%. Mother with hepatitis B 0.09%. Initial infection around 0.7%.
So in a nutshell, you would say that there is a sizable number.
There is a sizable number. Another important thing, as my previous speaker said, they see retrospective, but I see perspective. Why? Because retrospective is perspective. Because many of our interns will be born with IUGR. And in India, I think IUGR is a problem of our country. It's not a problem of the West. So you will see the IUGR interns and many of the direct interns, there will be some association of perinatal.
Okay.
And I wanted to see the data. In the data from our Institute of Medical Science, which was published in 2000. Their data is also showing like that. There are around 2.54 to around 2% of all admission of perinatal infection.
Okay. Okay. Thank you. That was very interesting. So we obviously need to pull up our socks and do our bit from each side as an obstetrician, as a fetal medicine specialist, and so that we cater to these patients properly and triage them properly. So let's go to the first case. She's Mrs. X, 32 years. She's had 3 spontaneous first trimester losses, has now come to us with 10 weeks of gestation, and her local, wherever she was showing to there, they did a torch test. So Dr. Rajiv Dhal, do you think this was necessary and this was indicated? Would you agree with this test?
Yeah, torch test, I think should not be done routinely in all cases. But, if you have some diagnostic...
In this specific case of 3 spontaneous first trimester losses, do you think a torch was required? Is it indicated, and will it be helpful in our management? Yes, or no?
Yes, I think it should be.
Okay, okay. So, considering disregarding that, what do you think is the role of routine torch screening in asymptomatic pregnant women? Like a lady comes to you in her first pregnancy, she's had no problems at all, or even in her second pregnancy, there's no history of any untoward events. Would you recommend a torch screening in these women?
No, I will not routinely. No, I will not routinely advocate a torch screening in a patient who has had no symptoms at all and she's in the first pregnancy. But if there's any diagnostic pointers, like if there are any...
No, I specifically said asymptomatic pregnant women. Yeah.
No,
so the consensus is there is geographic variation, of course, where we live. But now talking in India, as of now, we don't have any recommendations for screening for any torch infections in the pregnancy, especially for toxo and CMV. But in rubella, it is recommended to screen them at the prenatal visit. It is very, very important to screen them if they've had an immunization for rubella, and that will be only IG to establish whether they are immune to rubella or not. But routine screening for asymptomatic pregnant women is not indicated. Well, coming back to the question, when is it not indicated? Dr. Alpana?
We are going to the same point. It is not helpful for recurrent pregnancy loss, because because torch infection does not cause recurrent pregnancy loss, as we all know, and nowadays it's not recommended at
So
all.
FOGSI actually recommends that it should not be recommended as part of a recurrent pregnancy loss investigations, because that is actually not is the causative factor. We have to look for other causes. So let's move on to this case. Let's move on as to when would then be torch testing indicated in pregnancy. Debashmita?
Yeah, TORCH test would be indicated mainly for the maternal infection, recent maternal infection, if she is giving any kind of history, and ultrasound marker we are getting like IUGR, sudden IUFD you have shown, and many kind of ultrasound markers that we have already told in our previous slides. And those high risk patients who have been in the recurrent IUDs or recurrent IUGRs, those kinds can be also indicated for the TORCH. I think so. Yeah.
Or if she's coming from any high-risk group,
Endemic.
like, even for the Zika virus nowadays, if they're traveling from endemic areas or they're immunosuppressed like HIV patients, then they would obviously need to be screened for torch infections. So this lady, she returns at 13 weeks for her nuchal scan, and then now she gives history of exposure to somebody with a flu-like illness, which is possibly rubella. Of course, her combined screen was negative, and then we did the rubella test, the torch test, where the rubella IgG and the IgM came positive. So, Kanchan, Dr. Kanchan Mukherjee, considering that this could be rubella infection, what do you think is the risk of infection to this fetus at 13 weeks? What and how, when is the infection most severe?
See, as a general rule, for all infections, the fetal infection is pathogen and gestation specific. Now, for rubella, the risk is maximum when the infection happens in the first trimester, up to 12 weeks. Now here the infection has seemed to have happened at 13 weeks. So I would put her at a very high risk, like around 90% with multi-organ problems, and the problems can affect the cranial system, intracranial changes, cardiac changes, sensory neural deafness, cataract. There can be many problems.
So rubella, as you rightly said, Kanchan, rubella is unique in its way that it is basically an embryopathy. It affects the baby, affects the embryo, and if that the infection has occurred, the affection to the baby is also severe in the first trimester. So, but as the gestational age advances, we can see the risk goes down, and after 20 weeks, almost there is no additional risk, especially there is no risk of deafness after that. Right. So this is again quickly to say that it is basically happen, and the baby can end in a miscarriage or with congenital rubella syndrome if you have missed it, and then they can present at birth or later at birth. So in this case that she's IgM and IgG positive, Alpana, what will you do? I mean, how will you interpret this serology? And what do you understand by this IgM and IgG positive in rubella, in suspected rubella patients?
IgM is usually positive around 5 to 6 days after infection from rubella virus. It takes that much of period. But if you have positive IgM, it is not specific of rubella. As you've already said, that screening for rubella and history taking is very important. You should inquire whether she has had a previous injection of immunization against rubella, or there may be a past history of rubella in a previous she might have that infection, so that might turn out to be positive too. So it is not specific, and IgM assays have some sort of false positive bits. So after that, you have to do rubella specific, and immunoglobulin G is needed to confirm it, and even it should not only be relied upon IgM antibodies, and even the repeat serology should be done after to again reconfirm it. And most importantly, as Dr. Kanchan has already said, rubella IgG avidity test is a must to diagnose.
So any sort of, if it's IgM and IgG positive, we know that there is a false positive rate. So that's why we need to repeat the serology to see if there is any increasing titers. And as Kanchan said, the avidity test to see whether this infection is recent or late. So this is just a table to show that, if you do a rubella testing because of contact, and if she's IgM and IgG negative, then she's susceptible. But of course, you have to repeat it after 1 month to see because she has a history of contact. If there is no history of contact, we know she's not immune, and then we might just leave her there. But there is history of contact, you are suspecting, you have to repeat it. So generally the bottom line is you have to repeat the serology, and in our case, if the IgM and IgG is positive, you repeat it again in 2 to 3 weeks time and measure the IgD avidity depending on to see whether it is a primary infection, a recent infection, and also to detect a rise in IgG titer. If it is IgM negative and IgG positive, that means it's a past infection. But again, you have to repeat it again after 4 weeks or after 2 weeks in our scenario, because there has a history of exposure, to see if there is a rising titer of the IgM is becoming positive. And if it's IgM positive and IgG negative, again, if there is no seroconversion, you can, this is a false positive IgM. But if there is a seroconversion, that means she's become positive. I hope this is clear. So any sort of serology, you will need to see if there is a rising titer, and to also look at the avidity test. And of course, the risk of fetal infection is usually less when there is a secondary infection. So what we need to decide is whether this is a primary infection or not. Again, the same thing, telling about the serology, I'm not going into the details. So if you consider that this infection has happened in the fetus, how will you confirm the baby is infected, Devashnika?
Yeah, that is actually confirmation is by the PCR test. Polymerase chain reaction, that is very much confirmatory, and we need to go for the amniotic fluid polymerase chain reaction for the rubella virus, and we need to go through the amniocentesis. That is actually 90% almost sensitivity and specificity almost 100%. That is the only way we can confirm the diagnosis.
So suppose this avidity was low, and that means it's less than 3 months. And would you do the amniocentesis now, or when would you actually time the amniocentesis?
We need to wait for at least 6 weeks. At least 6 weeks in case of rubella, because there is and for the 20th week of the gestation, if the recent infection has happened, we know about the recent infection very clearly, then we need to wait for the 6 weeks. But the amniocentesis has to be done at least 18 to 20 weeks. At that time, the fetal urination established.
Yeah.
So that's
we have to isolate the virus from the amniotic fluid, and that will happen only when the fetal excretes the virus through its urine in the amniotic fluid, and that can happen only after 20 weeks. And then that's why we have to wait till 20 weeks or the infection 6 weeks after infection. Okay, thank you. So then, of course, this patient lost to follow-up, as we normally have with all our cases, and possibly she has terminated the pregnancy because they might have suggested that she's infected. And it's going to be grave consequences. So unfortunately, rubella, we have to stay that WHO still says that we, and as a country, lack in this, because it is still a leading vaccine preventable cause of birth defects. We still see a lot of babies with these, and that's why mainstay is prevention, and pregnancy should be avoided up for a month after vaccination. And a very important point to note, that if the pregnancy does happen, you don't require to terminate the pregnancy. Right. So, Dr. Bijan Shah, how do you confirm infection in these neonates who are infected with rubella?
Actually, most of my questions have been answered by the previous speakers. Still, when I say get a case, suspicion of congenital rubella syndrome, first one I do my history. If there is congenital rubella syndrome markers, then what? Say, as a clinician, you have got 2 or 3 options. You can either isolate the virus, or you can see the serology. As serology is confusing, as most of you have said, isolation of virus is where it is possible, and it is not very cost effective, and it is not available also. And cultural
Excuse me, Dr. Shah, your voice is not very clear. Can you just come closer to the mic?
Now it is clear.
Yeah.
So, as a clinician, what we do, whether we isolate the virus or we do go for serology. And as a clinician, what we do actually, we do the clinical signs and symptoms. As you have rightly pointed out, many of these impacts involve with eye fear and confirmed heart disease like that. Isolation of the virus also can be done, but it is not clinically practical use. And PCR does not exclude the infection, and also it takes several months. But one of the most important things that we do in clinical practice is see the rising titer. Rising IgG titer for more than 4-fold within 2 weeks is very much suggestive. So that is the test we do actually in clinical practice. And IgM, it may show recent of postnatal congenital infection, but it is not that specific and may last for weeks. So if you say the diagnosis, the history and the rising IgG titer, that is more clinically and practically.
So along the same lines as we would diagnose in the pregnant lady.
Right.
Absolutely. Thank you. So we go on to our next case. This is Mrs. Y, and she's a 30-year-old primey with history of blood transfusion in the past, and her routine antenatal screening, as we would recommend to all, comes as a positive for HIV, and her husband is tested negative, and now she's 10 weeks pregnant. So, Dr. Rajiv Dhal, what do you think is the burden of HIV in India now, after all the preventive measures, and what is the risk of fetal infection to these babies with all these preventive measures?
Well, at the present moment, the current burden of HIV in India, or people who are living with HIV, would be about 2.3 million, which has been there since the last 10 years or so, but it hasn't grown that much because of very good preventive measures. And the prevalence rate is about 0.3%. But the worrying thing is that 39% of these patients are women, and the number of women who become pregnant with HIV is, the population that we have to deal with. And the mother-to-child transmission may be as high as 20 to 45% if there is no intervention. But if there is good intervention and prophylaxis, then the MTCT can drop to
with effective intervention
with ritonavir, lamivudine, and efavirenz.
Yeah.
So this, and apart from that, you can also give her prophylaxis if the CD4 count comes less than 250 cells per cubic millimeter. So you start with prevention prophylaxis with trimoxazole.
Absolutely. Counts to count. The minute you see the report, you must ideally send them to an ART dedicated center, and then they should be started on these therapy. Dr. Devashmita, what other tests need to be done on these women because they are immunosuppressed, they are more likely to have infections, and what else would you do antenatally?
Routine antenatal investigations should be always advised.
Apart from that, in specific for these women?
Yeah, and in specific, it is the confirmatory test for this ELISA. It is for the screening, and for confirmatory, we are sending for the Western blot. And by after confirmation, we have to know what is the status of the HIV, how is the how is the matter of the immune suppression is going on. So it's by the CD4 count and as well as the RNA copy titer for the HIV itself, because it is going to give us a decision for this, how to carry forward the art, how to carry forward its preconceptionally, as well as how to carry forward the decision of the delivery, the way of delivery. So the whole gamut of things will be depending on this RNA copy titer as well as the CD4 count. That has to be, CD4 count has to be less than more than 350, and RNA copy has to be more than 55,000. This is the actually sign. These are the signs for the well immunity of that patient. So these are the particular things we have to go on. And for the HIV mother, we have to go for a regular ultrasound monitoring for the growth of the baby, because these babies can suffer from intrauterine growth restrictions. That is very important issue we have to carry forward. And as well as they can suffer from preterm labor, this HIV infections. So we can go for a cervical length scanning during our ultrasound routine scanning. We can go for those things for the prevention of preterm labor. We can help them out. And as well as for the other type of fetal taking care of the babies. And another thing, if the HIV titer is DNA titer is very much high, RNA copy titer is very much high, we should go for a maternal echo as well as, because they can suffer from cardiomyopathy as well as HIV induced. That is very common in HIV-induced cardiomyopathy. During the, maybe they may be asymptomatic during their antenatal period, but during the third trimester or during the labor, it may happen, they may suffer from heart failures. So we have to go for this kind of investigations for this antenatal HIV.
Thank you. So that was much more than, in the sense we have to look for the mother and the baby respectively, and you look for opportunistic infections as I've mentioned here, and also what Devashmita has added. So in respect to obstetric management, is anything different for these women, Dr. Alpana, or we use the same preventive measures like for any other women?
First, I would like to say cesarean section, first of all, is not an indication to prevent maternal to child transmission in HIV. So cesarean should be always reserved for obstetric conditions only, any cases if required. And secondly, a health worker should ensure that the ART, which is given to the patient, and in case of elective LSCA, she should at least be given ART before performing a cesarean section.
Absolutely.
And if not, then you have to initiate ART prophylaxis before doing any cesarean section. So in cases of labor, she has to, in cases of labor, certain precautions have to be taken not to increase the transmission of maternal to child HIV infections. Like we all of us know, you do not do early rupture of membranes, artificial rupture of membranes. You do not do frequent PV examinations, and even we avoid any instrumental delivery. If needed, Ventures should better be avoided, low forceps should be applied, and as soon as the baby is delivered, the baby is subjected to nevirapine prophylaxis.
Thank you. So then we move on to Dr. Bijan Shah about your views. I mean, what do we advise them on breastfeeding and early infant diagnosis, which is a major part of our care of these HIV babies born to HIV positive mothers?
So what we have learned from the previous speaker is that the risk of transmission is basically around 20-30%, what Dr. Ravi said. And from Dr. Devasmita and Dr. Alpona already have learned Dr. Diabetes and what treatment should be there. You ask me whether the baby should be given breastfeeding or not, first answer is yes. But how long? Baby should be exclusively breastfed, but at 6 weeks of age, baby has to be undergo the HIV DNA PCR test. And also should be continued for 1 year. It can be done at 6 weeks and 6 months. Then the second question is the mother doesn't wish to give breastfeeding, or mother dies, or there are some terminal diseases probably the breastfeeding or food not being. In that case, it can be only given if this applicable, accessible, sustainable, and safe. If these all these categories are true. Third important thing is that many times mother would want to be combined. So breastfeeding along with some artificial feeding can be more dangerous because it causes more blood injury than breastfeeding alone or feeding. That should be avoided. Second important thing is that sometimes, if I have learned from my previous speakers, if there is a high index of suspicion, mother will listen committee to know whether there is any risk of father infection, we take after doctor. Then WHO says that implicit testing can be done to know that whether there is related to the recognition of the disease or not. And second important thing is that if the baby is old, because we know that exclusive breastfeeding for 6 months, complementary feeding and breastfeeding will continue 2 years. At least our ceremony can be done at 18 months of age. That is what is commonly done. So this is about breastfeeding and the diagnosis. So diagnosis, first 6 weeks, the HIV DNA PCR, and 6 months also same. Nucleic testing can be done immediately after birth, and 18 months you can go for ceremony. And breastfeeding to be continued at any cost. But if the mother is not willing, or if there is death of the mother, then only can think of artificial.
Okay. So as clearly recommended, breastfeeding should be encouraged and the neonatal tested at 6 weeks and 6 months. So this is just another scenario. I'll move on to the final take-home messages for HIV, that better policies and improved health conditions have, more and more women are getting pregnant and having safe babies. Timely administration of appropriate ART, suppressed viral load, appropriate mode of delivery, and safe feeding practices and all can all reduce the risk, as we've seen, to minimal and can ensure a safe pregnancy for the mother. So we move on to our third case, which is Mrs. Z, and she's 34-year-old para 1, previous section, and her first baby is normal. No screening was done. She was referred to us because an anomaly scan was done at Patna. There was no, it's said to be normal, but there was no report with her, and she had a 32-week scan. She came to us for a growth scan, and this is what we found. Well, to say that she has a bilateral ventriculomegaly, both of the ventricles measured about 14 and 16. And as we would, routinely do in any cases of ventriculomegaly, we have to sort of look at the other, we do a detailed neurosonogram and also look for other anomalies, extracranial anomalies, because this lady has not had any specific screening done. And, sorry, I can't see my, Now we could see some sort of, cyst-like structures. We don't know if this is any clinical significant. It could be part of the choroid plexus, but we also went on to see that all her other extracranial, all her cranial structures looked absolutely normal with a normal corpus callosum, but there was ventriculomegaly. So obviously, as part of her investigations, she would have to have an infection screen. So, so Dr. Debashmita, what do you think, considering that this could be a CMV, because I'm targeting this case to discussion about cytomegalovirus, do we actually need to worry about cytomegalovirus? What is your opinion?
Actually, it is worrisome because it is one of the most common congenital infections, and it starts from the incidence of 0.2 to 2.2% incidence among live births, as well as, if we will calculate, it is actually the potential cause for sensory neural hearing deficit, as well as for the long-term neurological disability of the neonates, as well as in the long-term disability, it is counted almost in 25% of the cases, as well as if we count for the other things, it can cause major neurological disability in the adulthood as well, if the baby is going to have to live up to their adulthood. So these are really concerned. And another thing is they can affect in the third trimester almost in 50% of the cases of the fetus. So that is really alarming. When we are going to deliver the baby is already affected with 50% of the incidence. So that's it.
As she rightly said, it's one of the most common infections affecting congenital infections that we see, and most of these cases go undiagnosed because of the patients being asymptomatic and the babies presenting with features, and when they're already presenting with features, the damage is already possibly done. So this case, with regard to CMV, what is the risk of fetal infection and affection, and how does it differ from rubella? Dr. Kanchan?
Yeah, cytomegalovirus is unique in the sense it is more dangerous as it proceeds towards the term for vertical term transmission. But funnily, if the fetal infection happens later in pregnancy, the fetal affection is milder. So that is very interesting thing. So primary infection, the overall risk is around 35 to 40%, as you have already mentioned on the slide, and risk reinfection by a new strain or reactivation is, if it happens, the risk of transmission is low.
But the risk of infection is still there. It's not completely gone. So
it is there. Yeah.
So as Dr. Mukherjee rightly said, the risk of vertical transmission, placenta acts as a barrier in the first trimester, so it protects. But if it does pass the placenta and affect the fetus, the infection, the fetal affection can be very severe in the first trimester. But as the pregnancy advances, the risk of transmission is higher, with the infection rate being lower. So again, as put it in a format here, if it's a primary infection, that is in symptomatic congenital infection, the risk of sequelae is almost 50%. Also in asymptomatic congenital infections, which are more or less 85 to 90%, where you might not see any features or subtle features, risk of sequelae is almost about 15 to 20%. If it's non-primary, though there is a risk of transmission is low, there is a risk of sequelae there, and we cannot completely ignore that as well. And that is the difficulty, because we can't diagnose these non-primary infections very clearly. So she comes back with a report of CMV IgM negative and IgG is positive now. So what do we do next? I mean, as we've said earlier, this is a paired serology. We've got these reports. Do you think that we need to do anything here? What is the role of IgG avidity here now at 32 weeks?
So the peculiar thing about the serology of CMV is that IgM usually persists for about 3 months in most of the cases, but in some cases, like 25% of the cases, it may persist for about 1 year.
Absolutely, yes.
So it's very important to do the avidity test. And if the avidity is found to be low, say below 0.6, the avidity index, then you come to conclude that it's a recent infection or a primary infection. But if the avidity is high,
so as Dr. Rajiva said, it's very, very accurate that usually with CMV, you cannot rely completely on the IgM because it persists for many months after the primary infection, and it may be detected during a secondary infection also. And that's why CMV specific IgG testing should be done along with the IgG avidity. Now, knowing that this avidity has been done, And of course, as I said, a rise in IgG levels does not confirm secondary infection. So this is very important in CMV, that it is very difficult to diagnose secondary infection, and even when there is secondary infection, the risk of affection is still there. So considering that this IgG test was high, what does it mean, Kanchan? And considering that she's 32 weeks and now the IgG test is high, what does it mean to you?
That the infection has happened more than 3 months ago.
Right,
and
but now she's 32 weeks.
Yeah, that means the infection might have happened in the first trimester or in the early second trimester.
Absolutely.
So the chance of fetal affection is more here. Severity of the fetal problems.
Absolutely. So basically the IgG test does not mean much here to rule out with a negative predictive value, because the infection has occurred. Maybe in the first, it's more than 3 months. The mother might have been infected in the first 3 months. So that still doesn't prove anything whether she was infected or not, or it'll be more than that. We just know that it's more than 3 months. We don't know where exactly that was done.
Exactly.
So in this case, how do we diagnose fetal infection? And is there any role of any other imaging modalities?
Now, the mainstay of fetal infection is amniocentesis, as Devasmita has pointed out. But what is the point of doing an amniocentesis at 32 weeks? Because you are in any case continuing, and if you are doing an amniocentesis at this late stage, you might trigger a premature labor.
Absolutely.
So probably I would avoid invasive testing here, but I would work on non-invasive methods of detecting fetal affection, like ultrasonography and or fetal MRI.
Right.
Now, whether we would go for ultrasonography or MRI is a different issue. Should we touch on that as well? Should I go on to that?
Because, considering that we don't have very good facilities for MRI, though the guidelines do mention that if possible you should do MRI. So you can give me your opinion about that. Yeah.
Well, they are rather interchangeable and complementary to each other. Now, with high resolution modern ultrasound machines, MRI does not really score much higher above these ultrasonography modalities. It only detects, say, for example, periventricular calcifications slightly better than ultrasonography. But having said that, if the calcifications are the only isolated finding, the fetal prognosis is not that bad. Then on the other hand, if MRI and ultrasonography are both normal, you can reassure the mother that the fetal affection is not going to be that high. Again, there is a caveat that if all ultrasonography and MRI are normal, you cannot still exclude, you cannot still rule out the possibility of sensory neural hearing loss.
So thank you, Kanchan. That was very clear, that basically that we should be offering them amniocentesis, but again, we have to weigh the pros and cons about doing an amniocentesis at this stage, whether it is really going to help us. Yes, we might have a diagnosis and, there is treatment coming up, but it's still in experimental stages. But for any infection, you must delay the amniocentesis, as we've said, 6 to 8 weeks after the estimated time, and they are complementary. But the important point to note is that as he said, that if we'll come to that in prognostic indicators. Devashmita, what do you think will be the prognostic indicators? Like, as he said, if the ultrasound shows features of, ultrasound features, that means the baby is already infected. It is pretty late. And if the ultrasound is normal and we're suspecting infection, they could be good indicators. So what do you think are the prognostic indicators?
Prognostic indicators, basically, it can be prenatal and neonatal. Neonatal part, Dr. Bijan can deal with actually, and we can deal with the prenatal. What we have already told, the CNS lesions that can happen, these are the major prognostic markers. The CNS, if it is a cranial involvement is there, it is actually majorly changing the whole outcome of the scenario, whether to terminate the pregnancy, whether to carry forward, many kinds of things, and many kinds of inclusion in the counseling to the parents will be included. Extracranial cranial malformations like cortical malformations, if there are, or any kinds of mild ventriculomegaly is okay. But if it is a major ventriculomegaly with many kinds of synechiae, many kinds of pseudocysts, or kind of Salzigare absence, or many kinds of other things will be there, then it is going to have a havoc prognosis, bad prognosis rather. And regarding growth retardation, we should not forget that actually. That is also a another kind of thing. Even a small for gestational age baby can have a neurological disability later on, even without any kind of malformation within the structural malformation within the baby. So many this kind of things like intrauterine growth retardation, that can be also counseled in a better way, so that the affection with CMV, with IUGR, how these babies are going to in a 5 years follow-up, we have to counsel properly. So these are the prognostic markers, we have to say them properly.
Yeah, so the bottom line is, as we mentioned, that first trimester is obviously more severe if the fetus gets infected, and presence of abnormalities will so they say that there's better or good prognosis. But of course, if there is no lesions, that doesn't mean that this baby is going to be completely normal, because most of these babies still have sensory neural loss, as we'll hear from Dr. Shah. And there are some other category, other parameters which routinely is not done. So as as we would have expected, this patient refuses any intervention. So Alpana, what do you think? How should we counsel and follow up these women? This lady has come at 32 weeks. She could have an aneuploidy also because she's not had a screening. But because we're talking about infections, how are we going to follow up this lady, and how are you going to counsel her?
We have to tell her, though even if her ultrasound reports are normal, that baby might be present with symptoms after birth. And it may so happen that any abnormality in the ultrasound will be present after 3 months or so. So it can happen thereafter also. So we advise her to go for a routine follow-up. At least 2 weeks or 3 weeks of follow-ups can be done to see things, how it turns out into.
Yeah. So Kanchan, do you want to add on to this? Like, with this obstetrician refers this patient to you for follow-up scans, how frequently are you going to do the scans, and what are you going to be looking for?
Yeah, I agree with Alpana that every 2 weeks, I would say, till delivery. And there has to be a discussion of antiviral treatment, even though not well established, not clear benefit, but the discussion must happen about valacyclovir, things like those.
But that would happen only if you have confirmed amniocentesis report.
Fetal affection,
isn't it? So then in that case, if you have to consider discussing these treatments with them, you will have to do an amniocentesis and prove that the baby is CMV positive, right? Without that, we cannot be offering them any treatment as
That's
such.
Right. Yeah.
So again, this is a flow chart, as to say, again, for taken from the guidelines, that if your fetal infection is confirmed by amniocentesis, you do a target examination every 2 to 4 weeks, ideally every 2 weeks, and then an MRI if you are available. And then they have classified into different types, and then you can, if it's asymptomatic or mild to moderate, you could consider there's an experimental, though they stay under research settings, there have been reports using valacyclovir and sometimes immunoglobulins as well. So coming to Dr. Bijon Shah, how do we diagnose infections in these women who are suspected CMV infected?
I'm lucky to see that because I have got enough food from my rates, many times we go get. And second importantly, mother improves condition. So my concern is that why I am interested to diagnose CMV in human on a development education, because I have no diagnosis in on mathematics. And if I have to diagnose, I have got two options. I will give you any evidence, either serology or isolation of virus. But here serology is not useful. That's one. Right. Isolation of virus PCR DNA is very, very important. For one reason, I think that the other speakers have already told. The sensitivity is very low. Suppose HMV either urine or PCR saliva is positive, that means there is a fundamental CME infection. In that case, if there is a severe symptoms, then we can start with a TB. But if there is no severe infection, then we can watch. And second, third, some are important issues very similar. These babies will be coronavirus for neurological examination because it does not cover awareness. Second important, some more investigations like CT or MRI can be asked for if it is required, and some liver and lung function test. So diagnosis by urine or saliva, and saliva easy to collect, but then urine. So in some centers they say they collect saliva, but the problem is that if you cannot diagnose only 3 weeks, then you have missed the bus. Then it is more than 1 month, even if you can diagnose, you can be missed. So that is the way we can diagnose and go to and follow the disease like that.
And by when do you think we can diagnose this sensory neural loss?
Sensory neural loss can be diagnosed at birth, because now there are investigations usually done on day one. You can use sensory neural loss. There are investigations.
So that's important. And how long do you follow up these babies for?
At least 2 years, because sensory neural we have 2 years. At least for 2 years.
Okay, thank you. So any role of prevention, Dr. Rajiv Dal, in considering that this is one of the most common congenital infections that we see?
Yeah, unfortunately, there is no vaccine for CMV.
Yeah.
But we just have to follow good hygienic practices. Avoid keeping pets or small children. To keep hygienic practices. Or wash hands whenever you come in contact with diapers and urine samples.
So because it is mainly transmitted from young children and women who have young children at home, and they don't, there is a chance of getting infected from these asymptomatic children who might have this disease. And so you have to thoroughly wash your hands, especially these women who might be pregnant, and avoid sharing of, because we still don't have a preventive vaccine. Thank you, Dr. Rajiv. And so it's still a challenge because the maternal infection is asymptomatic. There is absence of universal screening in mothers. There is lack of effective treatment. And as of now, there is still lack of awareness, and still we don't have, the diagnosis can still be a challenge. So do we have time for the fifth case? Let's quickly go on to this. That this is a lady who came only about a couple of days ago. She's 36 years old, positive quadruple test for trisomy 21. And she had an NIPT, which is, I'm not going into the details, but that was low risk. And then she had an anomaly scan at 19 weeks done outside. And this, they also did a torch test. I don't know for what, but the torch test, the toxo test was done in IG in November 20, where you can see the toxo IgM was positive, IgG was negative. And then it was repeated very rightly on the 1st of December, where the IgM and IgG both are negative. Okay. And she also has this ultrasound report with her, where it says that there is a discrepancy in her dates, and there is early IUGR, and with no other anomalies. They've had a look at the baby very well, and there was no anomalies also found, but they found IUGR. So Dr. Alpan, they're suspecting toxo in this baby. Do you think it's a problem? It is a problem in India?
The rate of toxoplasmosis in pregnancies is around 4% in India. So it is seen that, if I look at the seroconversion, around for seroprevalence is around 45%. So,
yeah, this is basically a paper that was recently published from North India, where they had this, they did say that, especially Dr. Salman Singh, he said that it is a problem in India, and people are not realizing it because people do have cats. It's a fashion nowadays to have cats as pets. So, it's there, but people are not really aware of it. So as you would say, the incidence rate is less, but it is still there. Dr. Kanchan Mukherjee, how will you interpret this report that this IgM was positive initially and then became negative?
Yeah, so IgG was negative and negative again.
Yes, yes.
That makes me think whether that IgM was very reliable, whether that was false positive, because
Absolutely.
if it was true positive, IgG should have been positive later on the second test. Now, in general terms, it is IgM that appears and reaches to its maximum level at around 1 month, and then may stay in the circulation for a long time, for many months. Whereas IgG appears after about after 2 weeks, reaches its highest at 3 month level, and then can stay lifelong. So that's in general terms.
Absolutely. So considering this, that if it's IgM and IgG negative, there is no past infection. You just educate for hygienic practices. In Our Lady, let's see, she was IgM positive, IgG negative. The test was repeated to see IgG seroconversion, as Dr. Kanchan.
Can I make a point here, Sita?
Yeah, yeah.
I think the test was repeated too soon. See, it was done in November 20 and then repeated on 1st December. So maybe a report done later may have caught the positive IgG.
Possible. So we still have to, that's a very good point. And then but the important thing to note is that there is, to see is whether there is IgG seroconversion. And if the repeat IgG still remains negative, which is most likely a false positive test. Okay, and then if both are positive, is suggestive of acute infection, we would still repeat the test in 2 to 4 weeks and then do the IgG avidity test to see if it is a recent or a past infection. Now, importantly to notice that it is very important that you send the sample to a standard reference laboratory and not to different laboratories, because the testing, as we have for other samples or other infections, it is important that the same lab tests for that specific toxoplasma infection and see whether the titers are rising or not. And again, to confirm, if we had a saved booking sample, we could have seen if there was seroconversion now or later. So what is the infection or risk of infection to this fetus in toxoplasmosis, and what are the features of infection? Devashmita?
Actually, it is almost 20 to 50% chance, the fetal infection without treatment. That has been seen. And the features of the infection is actually what we have already explained. Cranial malformations are less little bit with the toxoplasmosis than the cytomegalovirus. Microcephaly can be a formation, but it is a later on in a very rarely it happens with toxoplasmosis, mainly the calcified things like what we have already told about ascites, pericardial effusions, and we can find the abdominal calcifications, we can find echogenic bowel. These are the most common findings with the toxoplasmosis, what
Absolutely.
we have already explained. Yeah.
So just like CMV, as we've said, that the infection is low in the first trimester. Again, placenta acting as a barrier, but if it's infected, there is a high risk of fetal affection. And then, of course, you diagnose with, as you said, whatever the features are. So, Dr. Rajiv Dav, what do you think is the available treatment we have with these women if they're diagnosed with toxoplasmosis infection?
Well, you have to treat the mother with spiramycin. That's the drug available for the
spiramycin is mainly to prevent transmission.
But once you have diagnosed that the baby is also affected, the fetus is also affected, then you have to give additional treatment in the form of pyrimethamine and sulfadiazine.
Absolutely.
And you have to supplement that with fulinic acid as well.
Yeah, so once you diagnose, you suspect infection in the mother or you confirm infection in the mother, you have to start her off spiramycin. So this is one of the only infections where we have available treatment, which is very effective. So spiramycin, as I said, 1 gram taken 3 times a day to prevent vertical transmission. And once the vertical transmission is confirmed, you start the mother on spiramycin and pyrimethamine. It is continued throughout pregnancy and the infant is, of course, treated. You cannot forget the baby. You have to follow them up because some of them, some of them will have features which are evolving later on. So, Dr. Bijan Shah, what is your experience with toxo infection in children in our country, in our sort of state, in West Bengal? That we have seen this study from North India. What do you think would be your experience in East India?
As I told in my first slide, the incidence of this toxo is around 11.6% in our center. So that means out of 1,000 babies, around 1 or 2 babies in my case. But the problem is that treatment. I am not sure how much this pyrimethamine is available. Because last time I got it, that time it was not available. It is not readily available drug in India. But
sorry to interrupt, but we see a lot of patients getting unnecessary spiramycin. Don't you, the other panelists?
But I don't know. But in my time I didn't get it. And my baby had also CNS infection and there was hydrocephalus. And that's why we started steroid also. Dr. Devashmita says that in CMV there is more microcephaly, but in toxoplasmosis, hydrocephalus is more common. In our case, we did a scan and then we did drugs also. In India, not only toxoplasmosis, I think as a whole, all these perinatal infections do not very often think, because the bulk of this patient may not be very high in the center where the number of diseases tests. But in the center where I am working, there is not less. In a year, we can get 3 or 4 babies in 1 year, and these 3 or 4 babies should be treated. But the problem remains is that sometimes diagnosis and most importantly treatment. I think I will request you to give me the address of this pyrimethamine vendor where it is available. That will help me.
Sure. So interestingly, what we, as Tulika rightly pointed out, because this was done in a different laboratory, we have actually repeated this lady's sample for serology again in a standardized lab, which is in our hospital. And the scan which I did yesterday was absolutely normal. There was no growth restriction. So hopefully things are, reassuring for this woman, but we have to follow her up again and see what the serology reports are coming. So we are waiting for that. And so to conclude, I'll just say I wanted some concluding remarks from each of the panelists. So we'll start with Dr. Rajiv Dhal. Please, sir, if you could say your concluding remark.
Well, the concluding remarks is that to be aware of these possibility of these very serious infections, which can cause debilitating effects on the fetus. So at the slightest doubt, you must screen them and properly treat them well in time. That's the take-home message.
Thank you. Dr. Debashmita?
I will actually give the remark regarding the doing the serology tests and interpretation, as well as doing the amniocentesis in the proper timely interventions. That is more important. We have to know the incubation period of that particular infections, and we have to know when to do the interventions like amniocentesis to get the PCR test done and all that. That is very important.
How acceptable are these ladies to do the amniocentesis for infections? Let me ask you a practical question.
That is really difficult issue to
counseling as an issue. Yes, Dr. Alpana?
I think history taking of all pregnant mothers coming to your antenatal OPD, that is very important. And any doubt of any infection, you should subject those patients to sort of, rather than ignoring, to subject some sort of testings.
Yeah, thank you. And Dr. Kanchan Mukherjee, your expert.
Use avidity testing more commonly, more frequently.
Absolutely.
It's
Don't
very
be
cheap
afraid
and
to
it
use
clears
it.
a lot of.
Yeah.
Yeah.
Absolutely. Very important. Don't be afraid to use these serology tests and use our experts who are around to sort of interpret these reports for you. It's not a big deal. And don't terminate at the drop of a hat, because, some of these babies might be actually very normal.
Yeah.
Dr. Bijan Shaha, your expert comments to us, your messages to our obstetricians to, help us give you better babies.
Actually, that's one thing is that, as I was telling earlier, if I get some clues from you, then I'm thinking of perinatal infection, because then I can move early diagnosis. But what I have said in last 7 years, I think we should find out a reference there where the reliability of this test we can find out. Otherwise, you send the sample to two different laboratories, you will get two reports, and that will give you more confusion rather than a confusion. That is one. That I am not sure, because you can give me that idea which level that you should have. Second important thing is that unless the diagnosis is correct, then what you can do, and have the ability of that, because we don't have any choice on the drugs. Only things cancer you can give in case of LSI. But if you cannot diagnose before 1 month, then there is no meanings. As Dr. said, I think you should rely more on the ability test. You can one confidence rather than here and there. And what I feel, you can make a 1 page or 2 page a protocol and the certificate. That will help everyone.
Very good
because
point.
I think many of us are in confusion what to do, what should be done.
What not to be done.
I think it can be made, some refined, it is already done, and it will be make a document and that can be circulated to our obstetrics and the. And finally, I am very fortunate that I am with my obstetric friends, because you are the people who believe in your competition.
We need you also. We need your support as well to get these babies get better. So I conclude here, and everybody has rightly said that use your serology judiciously, and don't be afraid to use the avidity testing. And please don't terminate these babies. Again, counsel them and make sure that they are. Most of the times they might not be infected, but even then have necessary follow-up for all these women, and so that we can have healthy babies at the end. So thank you so much. I thank all the panelists for giving their valuable inputs, and thank you for allowing me to moderate this panel.
Thank you, Sitaji. Thank you so much. Thank you, sir.
Thank
you all.
Thank you, Sita, for that wonderful panel. It was very informative, interactive, and interesting. And all of us were really listening to all the important points which our esteemed panelists made during the past 1 hour. Thank you all panelists. Once again, thank you, Sita, for moderating the panel so well. Now we move on to the last part of the program, and I would like to invite Dr. Joyita Chakraborty to deliver the vote of thanks for the program.
Good
Over
evening,
to you,
everybody.
Joyita.
Yeah, can you hear me, please?
Yes, we can.
Yeah. We are thankful to Dr. Mandakini Pradhan, the chairperson of the Genetic and the Fetal Medicine Committee, FOGSI, for being with us and for your wonderful lecture, ma'am. Thank you, our chairpersons, Dr. Partha Bhattacharya, Dr. Narayan Jana, and Dr. Moushami De Banerjee. Thank you, Dr. Sukumar Barik, for elaborating on the consensus and the controversies. Thank you, especially our Joint Clinical Secretary, Dr. Sita, for moderating this excellent panel. And of course, special thanks to all our panelists, Dr. Alpana, Dr. Bijan Shah, Dr. Debashmita, Dr. Kanchan Mukherjee, and Dr. Rajiv Dal. A very special thanks to Dr. Jayantu Jana and the entire team of Pharmed for being our academic partner of this session. And last but not the least, thanks to all our audience who were with us for all this long and without whom this program could never be a success. Before ending, I just want to remind you to join us on 27th of February from 5:30 p.m. It will be a program on infertility, BOGS, along with the Infertility Committee of FOGSI. And we expect all of you to be there on 27th. Till then, good night, goodbye, and take care.